So let's begin. The lecture outline is going to be on this outline. That is, one is the diagnostic sequence. Then I'll be talking about the analysis of a symptom, then the complete diagnosis, and then we'll talk about the clinical evaluation types. There are two types in that. One is the comprehensive dental evaluation, and another one is the abbreviated evaluation. So this is the lecture outline for today. Okay, what do you mean by a diagnostic sequence? See, diagnostic sequence means it is a series of steps that enables the dentist to elicit and organize information. Means you're recording everything in a systematic order. What you have the case history is nothing but the diagnostic sequence. So you're following the steps to make sure that you elicit and organize the information from the patient. So why we are doing this is, in this way, we can make sure that all the information is collected, recorded, collated, analyzed, and constantly re-examined in the light of new information as they are gathered. And it's very simple to understand these two sentences. It's nothing but it's a systematic order which you are following, so that whatever information you're taking from the patient, that you're organizing it and then you're writing it down in the case history. So why we are doing this one is so that you collect, record, and analyze the information so that everything in the end you can reach to a final diagnosis. So this is what is called as a diagnostic sequence. Okay, now in this slide you can see the diagnostic sequence, the steps of diagnostic sequence according to the textbook. The textbook, according to the textbook of Stephen L. Bricker, these are the following steps. The first step says detection and examination of abnormalities, and the second step says history and examination of patient. Third step, it says re-examination, and then classification of abnormalities, and then list of possible diagnosis, which is a provisional diagnosis, and development of differential diagnosis, and then development of working diagnosis, and in the last is the final diagnosis. Now this sequence is according to the textbook of Stephen L. Bricker, which we are following. Now when you look at this sequence, I mean, the first step is usually the history and examination of the patient. We are not going to do detection and examination of abnormalities. So the more simple way of understanding the diagnostic sequence would be, the first one would be taking the patient data, then history, then you do the examination, then you do the provisional diagnosis, then investigations, then you do the final diagnosis and treatment planning. Okay, now coming to the analysis of a symptom, I'm sure you all know what is analysis of a symptom. Symptom is what the patient tells you, that might be pain, swelling, or bleeding, any form of complaint, what the patient tells you. So when you're analyzing a symptom, the first thing is the chief complaint. So the chief complaint, you have the total duration. It has to be with the total duration. Whatever the patient's complaint is there, that has to be with the duration. Then to take the history for this, for analysis of the symptom, you need to take history of present illness, that is mode of onset, characteristics of pain, then course since onset, so and any other information related to that pain or symptom. So what do you mean by mode of onset? That is, on which date did it start and how did it start, whether it started suddenly or whether it started gradually. Then these factors, whether there are any precipitation or predisposing factors, mean the patient experienced before the onset of the pain, did he experience any symptoms prior to that? And this characteristics of pain is very important. You have to ask for the nature, severity, location, radiation nature, and aggravating and relieving factors and associated constitutional symptoms. So just remember, when you ask for history of pain, there are 8 points which you need to ask. I think one is onset, duration, site, character, aggravating factors, relieving factors, radiating nature of pain, if any. So these are the questions which should flow when the patient tells you that he or she has a complaint of pain. Okay, now let us go through the oral diagnostic process. As I told you earlier, it is a systematic collection of data leading to identification of disease. Now, there are two types of clinical evaluations. That is, one is comprehensive, other one is abbreviated. See, comprehensive dental evaluation means what we are using in the clinics, what you're learning, that is the case history of the patient is the comprehensive. Comprehensive means it will be in detail. Means you have the patient data, name, age, everything. It is in detail. That is called as comprehensive dental evaluation. And this level 6, you're learning the comprehensive dental evaluation. And the other type of evaluation is the abbreviated evaluation. Under the abbreviated evaluation, you have where it is indicated. This abbreviated evaluation is indicated for screening and recall examinations or emergency examination. Abbreviated means it is concise, it is very small. You're not going to take more details of the patient. So when you have to use this is when there is some emergency examination or screening and recall examinations. So comprehensive is the one which you're learning in level 6. It is in detail. Now let us go through what are the where these are indicated. Okay, now you see the comprehensive dental evaluation will have 5 steps. First is taking and recording patient history. Second one is examination, and this examination can be general, extraoral, or intraoral. So once you finish the examination, the next step is provisional diagnosis. After the provisional diagnosis, you go for some sort of investigation, maybe x-rays, maybe blood investigations, or maybe it can be in the form of a biopsy. And then once you have the investigations report, you go for the final diagnosis and treatment planning. This is for comprehensive dental evaluation. So there are 5 steps: taking and recording patient history, examination, provisional diagnosis, investigations, final diagnosis, and treatment planning. Now, in which conditions are you going to use the comprehensive dental evaluation? See here the uses. The routine new patients means whatever the new patient comes to the dental clinic, you are going to go for a comprehensive dental evaluation. Or recall patients with significant changes. Suppose the patient has been recalled after 1 year or 6 months and there are many changes in the patient's oral cavity, then you go for the comprehensive evaluation. Or patients with complex problems as well. Complex means maybe some big problems, some syndromes or these kind of things. There also you're going to use the comprehensive dental evaluation. Now this is about comprehensive dental evaluation. Now let us look at what do you mean by abbreviated. I'm sorry, I think it's a problem with the graphics here. You're not able to see the complete slide on the screen. It's a problem with the graphics which are not working on this virtual classroom. Okay. Now in this slide you see about the abbreviated evaluations, and under abbreviated evaluation there are again 5 steps here: 1, 2, 3, 4, and 5. First one is minimal patient history here. See here, the difference between comprehensive and abbreviated is abbreviated, as I told you, everything is minimal, right? So here you have the minimal patient history, minimal examination, limited investigations, then you go for diagnosis, and then you go for treatment planning. Whereas in comprehensive, everything is in detail, but here you're limiting. Why? Because these type of evaluations are used in emergency patients or recall patients or large group of patients in community camps. See, suppose you go to some mall or some small village to conduct a community camp in dental community camp. There you might be having maybe thousands of patients waiting or hundreds of patients waiting. So in those circumstances, you cannot take a comprehensive dental evaluation. So you will follow the abbreviated evaluation, which includes everything in minimal. Like what is the most important thing that you're going to look in, take information from the patient. So that is about comprehensive and abbreviated evaluations. Okay. Now I'm going to discuss about the comprehensive dental evaluation in this slide. That is the complete diagnosis. The outline. Today I'm going to discuss just the outline and little bit details, which I'm not going to go totally in detail for each step, so that you have an idea when you start taking the patient history and examination. Okay. The first step, as I told you, for the comprehensive dental evaluation is taking and recording patient history. Now, under this recording and patient history is you have the following steps: patient identification data, chief complaint and history of present illness, dental history, medical history, personal habit history, and then family history. So this is this part you are just taking information from the patient. Means you are not doing any examination, you are just talking with the patient during this step. So you are just taking and recording the history of the patient, and then you are noting it down. Okay. Okay, and the patient identification data, you have name, age, sex, date, registration number, address, occupation, what type of education the patient is done, or it can be marital status, birthplace. So all these things comes under the patient identification data. And after the data, you have to ask for the chief complaint and history of present illness. As I told you earlier, when you ask for a complaint, maybe it's a pain, then you ask for the symptoms. That is, the symptom is the pain, so you need to ask onset, duration, progress, initiating, aggravating, and relieving factors, if any, for the chief complaint. That is, which is called as history of present illness. And one more thing I want you to remember, when you're asking the chief complaint to the patient, just ask the patient to describe the problem. Ask, may I know the reason why you have come to the clinic, or what is the problem you have? Then the patient will tell his problems. So, and remember, don't use dental and medical terminologies when you're writing the chief complaint. Means it has to be broad based. Suppose the patient tells you that he has pain in the upper teeth. So then you have to write down as pain in the right upper back teeth region, since one example is 5 days, like that, with duration. And don't write pain in the right upper molars or incisors or like that. You should not be using any scientific or dental terminologies. So once you record these two, then you go for the past dental history. And here the past dental complications are important, which you need to ask the patient. And then comes the medical history. And under the medical history, you're going to ask for the patient for any medical related problems for which he is taking treatment or which he is suffering. And you need to ask indirect questions here, mostly like, how is your health? Are you taking any medication, or were you hospitalized? In this way, you will get more information from the patient. If you ask directly, like, do you have diabetes, hypertension, the patient might say yes or no. But if you go indirectly, that are you taking any medication, or did you visit a doctor before? Why, for what reason you have visited? Like this, these are communication skills which you need to develop. So when you ask like that, the patient might reveal more details about the problems, and it has to be with you, since how many years the patient is suffering and what type of medication the patient is taking. And here in medical history, you also need to ask about the history of allergy, any allergy to medicine, food, or any other thing. After that, then you have the personal habit history. You need to ask about the brushing habits, tissue abuse habits like smoking or chewing tobacco, and parafunctional and postural habits. Parafunctional means which is not under your control, or like nail biting, lip biting, cheek biting, or bruxism. And then you also have the family history. Family history means the family members' health, like father, mother, brothers, sisters, and how their health is, or do they have any inherited diseases which might affect the patient, and all these things you need to ask in the family history of the patient. Okay, that is about the history taking part, outline. Now, why, in this slide, I'm going to explain it to you, why you are going to take history of the patient. What are the main objectives of taking and recording patient history? There is a reason, right, why we are taking and recording patient history. Okay, the first objective is to arrive at a tentative diagnosis of patient's chief complaint. See, tentative means provisional. Don't get confused with these names. There are different names for provisional diagnosis, like tentative diagnosis, clinical diagnosis, working diagnosis, or provisional. So all these are same. They give different names for the diagnosis. So to arrive at a tentative diagnosis of the patient's chief complaint, and to determine any systemic factor that might affect the formulation of a diagnosis, and to determine any systemic condition that requires special precautions prior to or during dental procedures. See these 2 points. Means any diabetes, any hypertension, or any cardiovascular problem that the patient has, this you're going to know when you're taking the history, right? So this, when the patient describes that he has some communicable disease or any other cardiac or respiratory disorder, you'll be prepared, so that you know what special precaution you might need to take during dental procedures. So this is also one of the objective of taking the history. And fourth one, to obtain written records for documentation, future reference, referral, research, and medical legal purposes. Means everything what you're asking to the patient, you're writing it down. And this one is going to help you in future when the patient comes back again for reference, or you want to refer the patient to some other doctor. You have the data, everything which is documented, or you want to do a research later on. you have the patient files, right? Everything is documented. And medical legal purposes. What do you mean by medical legal purposes? See, if there is some problem which happens to the patient thinks that it is a negligence of the doctor, then what evidence does the doctor have to protect himself? The written records of the patient which are available with us, that is the documentation which is available for the doctor to protect himself for medical legal purposes. That is why the case history documentation or any treatment, whatever you do, the documentation is very, very important. So this is also one of the objective. And the last one, to avoid possible disease contact. How is it going to help you, this one, to avoid possible disease contact? History. The patient might tell, something, he has flu, he has influenza, example, or he has some HIV, hepatitis, or AIDS, like that. So something like that, communicable diseases, right? When you use the history, you're going to take some more precautions when you're examining the patient. So these are the main objectives of taking and recording patient's history. Okay, that was the first part, that is the taking and recording of patient history outline. Now I'll go for examination. The second one here, the examination. So examination, basically you have three, this thing. One is general examination, the second one is extraoral examination, third one is intraoral examination. In intraoral, you have the hard tissues and soft tissues. Now, general examination means the overall health of the patient. Just remember, this general examination will begin the moment the patient is walking inside the clinic. Means you're going to start observing the patient, like how the patient is walking, how the patient is talking with you, how he's interacting with you, how his speech is. So that is the mental state or general appearance. All these things you're going to evaluate the moment the patient is walking inside. So once the patient is on the dental chair, you're going to check for some more things here. That is built, how is it built, well built, moderately built, or poorly built. Gait is nothing but the walking pattern. And you also have the vital signs here. The vital signs, which includes temperature, pulse, respiratory rate, and blood pressure, which you're going to check in general examination, or skin color, and you're going to check for the skin color for signs of some diseases like cyanosis, anemia, jaundice, or pigmentation, which can be there in the patient. You're checking here for signs. Anemia, for example, I'll just give you an example. Anemia is the decreased hemoglobin circulation in the blood. So where do you check for these signs? One is the nail bed, second is the lower palpebral conjunctiva or the lower eyelid, and third is the tongue. What happens is you get pale color. When it becomes pale, you can think that the patient is anemic. Similarly, you have something condition which is called as cyanosis. In this, the patient will become bluish in color. The skin and mucous membrane will become blue in color. And jaundice, the skin will become yellow in color, or any other pigmentation which you can see, that you have to note down. So once the general examination is over, then you go for the extraoral examination. So in the extraoral examination, if you imagine, when you look extraorally, what do we have? We have the head, hair, eyes, ears, nose, maxilla, mandible, temporomandibular joint, and then we also have some lymph nodes, which are superficial cervical lymph nodes, submental, submandibular lymph nodes. So these all things you are going to check in the extraoral examination. This is the outline of extraoral examination. Okay, these are the lymph nodes. Submental, submandibular, preauricular, postauricular, superficial cervical. So these are the different types of lymph nodes which are there in the head and neck region, but most commonly you will be checking for submental and submandibular, and this we all will show you during the clinical examination demonstration when you attend the clinical sections. I think already one batch has already completed, so next week inshallah we'll finish with the other group also, so that you'll have a clear idea like how to do the lymph node examination as well. Now just one more thing which I want you to remember is, when you're examining the extraoral examination or any clinical examination, basically there are three steps. One is inspection, palpation, or auscultation. What do you mean by inspection? Inspection means you're just looking with your eyes, you're just observing. Palpation means you're using your hands, to palpate, to check for any signs of diseases. Then auscultation, the third one, means you will be listening to sounds within the body. We have something which is called as a stethoscope, right? So this stethoscope can be used for examination of the temporomandibular joint as well, to hear for the click sounds like crepitus, click sound, all these things we can hear during the examination of the TMJ as well. Basically, any clinical examination, inspection, palpation, auscultation, or it can be percussion intraorally. If you're doing intraoral, it can be percussion. The third step will be percussion. Now this slide, you see the lymph node examination technique. This will show you in the clinic as well. This first picture here, what you see is for the submental lymph node. Look at the technique. One hand should be on the patient's head and one hand below the lower border of the chin. So normally, the lymph nodes, they will not be palpable unless there is some sort of infection in the body or near the head and neck region. Then only the lymph node becomes big in size. So in those circumstances, you need to check for these lymph nodes. This is for the submental and this is for the right submandibular. This side, the upper picture here, and this one, the third one here is superficial cervical lymph nodes. The technique is you should not extend the head backward. You should always ask the patient to look forward, bend down his head, and then you need to palpate the lower border of the chin here, below the chin here. And this is for the right submandibular lymph node. And this one will show you during the clinical demonstrations. It will be clearer to you during the demonstration of clinical examination. And this is for the temporomandibular. Just either you can stand in front of the patient or you can stand in the back of the patient. So when it's left to your comfort, and better is to do this examination extraoral in a standing position, and it will be more comfortable for the patient and for the doctor as well. Standing position for the extraoral examination. Whereas intraoral, you can do it by sitting or standing as well. There is no problem with that. So that is about extraoral. Now coming to the intraoral examination, these are some positions which are considered to be the best positions. There are two pictures here. We have four arches, right? Maxilla and mandible. First quadrant, second quadrant, third and fourth quadrant. The first quadrant is the maxillary right side. Then left. Then mandibular left side is the third quadrant and mandibular right side is the fourth quadrant. So when you're examining for the mandibular, for the maxillary teeth, for the first, second and third quadrants, that is the maxilla, first, second and the third quadrant mandible, better to recline the chair little bit on the back side of the patient, and then you sit little behind the patient, and then on a reclining and a sitting position, it's better to have a good view for these three quadrants, that is the maxillary first, second and the mandibular, with the third quadrant, which is the mandibular left side of the patient. Now for the right side quadrant, that is the fourth quadrant of the mandible, it is better to come in front of the patient a little bit and then examine. I'm not saying these are always required to follow, but these are considered to be the best positions in diagnosis during examination. So if you follow these positions, you'll have a clear visibility in the patient's mouth. It's easy to remember. The first, second and third quadrant, just little go behind the patient and then you see inside the oral cavity. Whereas for the fourth quadrant, that is the mandibular right side, you can just come in front of the patient and then you can do the examination. Okay, so that is about the positions. Okay, now coming to the hard tissue examination, we have different heart. The hard tissues are the teeth in the oral cavity, right? So the teeth might show many problems. So we need to examine all the problems in the teeth and then we need to note it down. So first of all, we'll see what is the type of dentition, by how many teeth are present or absent. Maybe deciduous are permanent sometimes, or maybe 32 teeth or some teeth are missing, or developmental disorders like number, shape, size, structure, or dental caries, which is very common. And you're also going to check for percussion check, which is vertical and lateral, or some defects like atresion, abrasion, erosion, discoloration, or deposits like plaque, calculus, mobility, and you're also going to check for pulp vitality. So these are all the things which you are going to examine during the teeth examination, which you will be performing. So I'm just giving you some examples here, like what are the problems which can come. There might be many other problems as well, fractured or swelling, broken teeth, discolored teeth, or so many other problems as well. Just to have an idea, you have to examine the teeth in systematic order. First count the number of teeth present and then check each and every tooth individually, and then we have to note it down in the case file. Yeah, now this picture is already blurred here in this slide. Apologize, I think it's the problem with the graphics on the this thing. So you can have this PPT is already there in the Blackboard in the lecture section, so you can check it there. Occlusion check means you have to check for the occlusion. You know the occlusion, that is the maxillary and mandibular teeth, how they are relating with each other. Normally you have three types of occlusions, that is class 1, class 2, and class 3. This also should be a part of your examination of the teeth, and this will explain it to you what is class 1, class 2, and class 3 during the clinical sections as we go through the lectures. Basically the three types of occlusions. Okay, now this is the percussion check of the teeth. You see this is the mirror and handle, so this is vertical, and the other picture here, this is the horizontal. See, percussion means gentle tapping of the incisal edge or the occlusal surface of the teeth. Means you're using the end of the mirror. You know, we have the mirror, right? The end of the mirror handle. So it should be a gentle pressure, you know, tapping the teeth. Gentle, this one, just tapping the teeth. So why we are doing this one is to identify whether the problem is pulpal or whether it is periodontal. So most of the times of pulpal or periapical problems, you have tenderness in vertical percussion, and whereas in periodontal problems the tooth will be tender on horizontal percussion. I'm saying most of the times. And this is for mobility check. You can either use two ends of the mirror handles or one finger with a glove and one end of the mirror handle. You know, mobility, tooth mobility, there are three grades: grade 1, grade 2, and grade 3. Grade 1 in two directions, labial and lingual. Grade 2, labial, lingual, mesial, and distal, four directions. Whereas grade 3, the tooth will be rotating or dancing in the socket. Okay, that is about the hard tissues. Now let us go through the soft tissues or the periodontium. First thing is the periodontium. See, periodontium means gingiva. So here gingiva is examined for signs of inflammation. Like I'll show you this slide, you'll better understand in this slide. Now see this picture here. In this picture, when you look at this is the periodontium, right? The gingiva which is surrounding both the labial or the lingual surfaces of all the teeth. Now when you look at the picture here, it doesn't look good. It doesn't look good, means that definitely there is some sort of problem. So first thing is when you observe the gingiva, here what you can see is in gingival inflammation, and here there is gingival enlargement, or you know, it's swollen, gingiva is swollen here, and then the position of the gingiva from the cervical margin of the tooth has come below. That is called as gingival precision. That is a contour. And then you also have a lot of calliculus plaque, and they tend to be, and there might be some periodontal pockets as well when you examine with a periodontal probe. So you need to check for all these things first, like one, how is it appearing, the gingiva, and then whether there is bleeding on probing. When you use a probe, whether there is bleeding, and then see the position of the gingiva, and then check for periodontal pocket. So these are the things you need to check during examination of periodontium. Coming to the step-by-step examination of soft tissues, that is the mucous membrane. I'll show you the pictures here. Yeah, you can see this is how we examine. This is for the upper labial mucosa. With your two hands, with a gloved hand, just retract the upper lip, and then here you can clearly see the upper lip mucosa here inside, and here is the labial frenum, and this is the vestibule here which is pointing. So everything is clear here. Similarly, the lower labial mucosa on the second picture here, you have to retract it and check. And this is the frenum here, this is the vestibule area, and this is the gingiva which is there here. And here on this part, in the lower labial mucosa, you see some small elevations here. I'm circling it here, you know, small elevations kind of thing, right? So these elevations are nothing but the minor salivary glands. Don't mistake it for any pathology. You have numerous minor salivary glands inside the oral cavity. So in the lower lip, it is more prominent. So when you retract it, when you see some small elevations or rounded elevations, don't confuse it for pathology. These are nothing but the minor salivary glands. Okay, then this is on the floor of the mouth, and here the tongue. For the examination of the tongue, you have two surfaces, dorsal and ventral. You have to hold it with a gauze piece, and then you have to check how the papillae are, or if there is any depapillation, redness, or swelling, and that you have to note it down. And this is the hard palate here. This is an edentulous patient, the first picture, and I'm sure you can make out there is some problem here, right? There looks like some ulcer, right? So this is an abnormality, right? So why I'm showing you this slide is when there is some abnormality like this, you need to note it down in your case file that there is an ulcer there, something like this. This is an edentulous patient here. And similarly, the second picture here, this one, the lower one, you see the ventral surface of the tongue. This is the ventral surface, the whole surface, and here is the lingual frenal attachment. So you need to ask the patient to lift the tongue and touch to the palate, so that you want to have an idea like how the lingual frenulum is there, whether it's high or low. Because once it is very low, or patient will not be able to move the tongue properly. That is called as partial ankylosing or tongue tie. The tongue tie, partial or complete, it can be sometimes. And in these regions, you also have the other salivary duct openings as well. Okay, here, here you'll have the salivary duct openings here in this region. That is the submandibular and sublingual salivary duct openings in this region. So that is a Wharton's and Bartholin's duct that I'll show you clinically again when we show you the demonstration. So that is about examination, general, extraoral, and intraoral. So once we finish teeth, periodontium, oral mucous membrane, then in the last, see this point, the third one, this is very important. Once you finish all the general examination of the patient, you need to examine the area of chief complaint once again. Once you finish all the examination, you are going to re-examine and again examine the area of chief complaint. Suppose the patient has complained that there is pain in the right upper back teeth region. That region has to be examined carefully once again. And then you have to note down all the findings related to that particular tooth or the area. So once you do that, you need to combine all the area of examination. Means whatever examination you have done, observations, all this, that you have to compile. I mean, you have to gather all the information, whatever you have, and then what you do is you do the provisional diagnosis. So that means you have the history, what is the complaint, what is the problem, and what is the general health of the patient, and if there is any abnormality extraorally or intraorally, examination also you did. So you're going to compile all those findings, and then based on the knowledge you have of the oral pathology, you're going to come to a provisional diagnosis. Provisional diagnosis means it is question mark. It is not 100%, based on the signs and symptoms and history, you are doing a provisional diagnosis. That is called as provisional diagnosis. So see here, this is the slide, like once you collect all the information, taking an examination. So third one, the provisional diagnosis here is the question mark. It's a question mark. To confirm this, what you need to do? You need to do investigations, right? You need to do investigations. So this one, as I told you earlier, for provisional diagnosis, there are different names: tentative, clinical, or working diagnosis. So don't get confused, when somebody tells any word in this, that means it is a provisional diagnosis. So once the provisional this thing, so as I told you, investigations. So once you do the provisional diagnosis, then you go for investigations. Now investigations can be of different types. Either it can be radiographic, either it can be laboratory or histopathology, or microbiology, serology, and immunology, right? So I mean, there are different types of investigations, but in this level 6, most of the times, we will just prescribe the radiographic examination to the patient, because you're just beginners, so you will not get any complicated cases. So most of the times it will be either radiograph, extraoral, or intraoral. But sometimes you might go for some histopathology as well, a biopsy or this kind of thing. So why do we need investigations? It aids in diagnosis, treatment planning, and also aids in prognosis. So this is the reason why we need to have investigations. So this is it: symptoms, signs, investigations, differential diagnosis, and knowledge of oral pathology. See here, this one, these pictures, what is a sign, what is a symptom, then you do the investigation, then you come to a diagnosis provisional, or then you do differential diagnosis as well. To come to these, you need to have knowledge of oral pathology, means knowledge of the diseases. If you don't have the knowledge of oral diseases, you will not be able to do the provisional diagnosis or the final diagnosis. See, that is the reason why we have simultaneous courses which are running together. We have diagnosis 1, you have oral pathology 1, and you also have radiology 1. See, all these 3 are interlinked. All these 3 are interlinked: diagnosis, radiology, and oral pathology. So then you will get the knowledge of oral pathology, then you will be able to do the provisional diagnosis or final diagnosis. So then in the last, as I told you, that is a final diagnosis which you will be able to do if you have the knowledge of oral pathology. So once the final diagnosis is done, now what do you mean the final diagnosis? See, the final diagnosis is not like a magician. This picture I'm just put a magician, right? Here he's investigating, or here you have the magician who's taking out a rabbit. No, it's not possible, right? You are the doctor, right? You are the one who is taking the history and doing the examination on the patient. Like you are investigating what is the problem in the patient. So you are the one who is going to find out what is the final diagnosis in the patient. So once you know the final diagnosis, you can plan the treatment properly to the patient. Now, what do you mean by final diagnosis? Final diagnosis means it's a, I'm sorry again for the slide here. The final diagnosis, I'll just explain it to you, is a firm statement regarding the nature or pathologic process affecting the patient. Means you're 100% sure that this is the problem in the patients. So once you do the final diagnosis, you have the treatment plan. Now, treatment plan objectives will be, first thing is to solve the pain in the patient. Means if the patient has pain, that you have to cure the patient from the pain or the disease. Then remember that pain is most important whenever you plan the treatment. If the patient has pain, first manage pain and then go to the other treatment plannings. Then, or it can be sometimes the chief complaint can be managed first if there is no pain in the patient or no acute infection in the patient. Now, after that, there is something which is called as a prognosis. Prognosis means it is nothing but prediction and outcome of the disease. Means you are going to predict that how, suppose you know there is a disease like periapical abscess. So you know how the patient is going to fare with this disease, whether it's going to be good, bad, or poor for the patient tooth. Whether you'll be able to save the tooth, then it's good. If you're not able to save the tooth, then the prognosis is going to be bad for the tooth. Okay, after the last one here in this diagnostic process will be the diagnostic summary. See this one, the diagnostic summary. This is also very important. See, what is diagnostic summary? Is a written narrative which should be a part of the patient's permanent record. Means here in the end of the case history, you will have one page or one paragraph on some space to write down a paragraph, you know, like why the patient has come to you, like what are the problems in the patient, all these things, you know, you have to summarize in your mind and then you have to write it down. See, this is something which is called as a case analysis, you know, or diagnostic case analysis. See, once you take all the history and everything of the patient, what is the point if you don't remember what the patient has told you? So that is the reason we have the diagnostic summary. So you need to compile all the important findings or the positive findings of the patient, starting from the age, chief complaint, till the treatment planning recommendations. So you have to put your thoughts into words, and this forces rethinking and reevaluation of clinical findings to date. So if you do this diagnostic case summary, that means you have understood the patient or the case. So understanding the case is very, very important. Each and every patient is different. So that is called as a diagnostic case summary. And this one, I just put some landmarks. See, if you want to describe something, some abnormality, you need to know the landmarks, you know, the extraoral and intraoral landmarks. This you had already learned in oral biology. I just put a picture here. You can just go through it later. I am not going to go into details. Now, you see here the first, this one, the pointed one here on this one, the black area, this is the ala of the nose. This one is the philtrum of the lip here. And vermilion border, this is the junction between the lip and the oral mucous membrane. And then you have here, this arrow is the labial commissure. On here, you have this arrow here is the outer canthus of the eye. And this one is the inner canthus of the eye here, this arrow here. And then you have the tragus of the ear here. The tragus near the ear, you have small elevation here, side that is called as a tragus of the ear. So suppose there is some pathology or some swelling here, right? Or the malar area. So how are you going to describe? So you can write down example, there is a swelling near the commissural area on the left side. So if you don't know the landmarks, you will not be able to describe the problem in the patient. When you examine for the sign, you mean you have to describe that lesion, right? So if you don't know the landmarks, it will be difficult to describe. Again, same Cupid's bow, philtrum, vermilion, oral commissure, and then you have the vermilion border. This one intraorally, you can see the parts, vestibule, mucogingival junction here, and here marginal gingiva. You know, the gingiva has different parts, marginal, interdental, free gingiva here, and then you have the attached gingiva here in the between attached gingiva. This is the buccal frenulum, mandibular vestibule. This all is the vestibule, right? The whole area, what you see is the vestibule and the maxillary labial frenum. So these are all the landmarks which you need to know when you want to describe some problem. So I'll stop here. So thank you for your patient hearing, and this is about the diagnostic process outline. If you have any questions, please go ahead. I'll try to answer.